Hello, so Assalamu alaikum. I'm Dr. Motia Noor, and today it has been my honor to again come back to you with another mock test. This time I have came with two stations. Actually, on our previous class, I have been there with you all, and I have discussed some topics like infective endocarditis, aortic stenosis, and giant cell arteritis. So today we are going to have a mock on that. I have prepared two stations, and I could see there are some participants here present with me. So don't worry, it will be just a conversation type mock. Okay, this is not an exam, but it is a type of exam. So here at first, uh, before the exam, you're going to have 1 or 2 minutes. Okay, that is a resting station where maybe you will have 1 minute actually. Where there will be a chit. Okay, there they will write down the topic or there will be a brief explanation. There will be a history, and according to that history, you inside the station, the examiner will ask you some questions. Okay, so and sometimes people do say the stations are really lengthy. Sometimes they do say it is a small station. So it is up to the candidate's luck actually. So here, like in case of infective endocarditis and aortic stenosis, it is a big station, to be honest. And within 9 minutes, because 1 minute is outside the station, you have to complete the whole thing. And also they have something called a checklist. You have to just here what they say are checklists. Like there are like some important points noted down, which if you do say in your exam, they will give you mark. When you will say the word, they will tick it. So that is a checklist. At that time, don't think what you have said in the checklist or not. What you have practiced here, you're just going to say in the exam. That's it. Okay, so let us start. Is there any participant who want to practice with me? Anyone?
Yes. Hello, I'm Dr. Piali. I want to
Oh,
participate.
okay, yes.
Okay.
Okay, so my first station. Infective endocarditis and aortic stenosis. Is my screen visible?
Yes.
Okay, here it will be kind of exam, but I think what do you prefer? Should we like have a discussion over that? Like we will just have some question and answer. That would be better, or you want to go through the whole mock? Then we would have this question answer session.
First of all, I want to go through the whole mock, then question answer.
Okay. So this is the scenario at first. Okay, a 56-year-old lady with a bicuspid aortic valve is admitted for laparotomy. Okay, so what the first question? Why is bicuspid aortic valve susceptible to infective endocarditis?
Because in case of bicuspid aortic valve, there is a two cusp and it causes more prone to stenosis, sclerosis followed by stenosis, which causes stasis of the blood followed by bacterial colonization, which causes further inflammation.
Okay, the pathogenesis of infective endocarditis in bicuspid valve.
In bicuspid valve.
Yes.
In bicuspid valve, there is a two cusp, so which will be progressively fibrosis followed by sclerosis and stenosis occurs. And as the stenotic valve causes stasis of the blood, stasis of the blood followed by bacterial colonization and inflammation, which leads to the infective endocarditis.
Okay. Then next question. Investigation of choice to identify vegetation in infective endocarditis.
Vegetation in infective endocarditis, 2D echo, transesophageal or transthoracic.
Okay. What are you looking for? 2D echo.
In 2D echo, I will see valvular valvular regurgitation, and in leaflet, their thickness prolapse, and annular elongation, cloacal, chordal elongation, and ventricular dysfunction, abscess, etc.
Okay. Then, next question. What is the cause for sudden death in aortic stenosis?
Myocardial infarction and rupture aortic dissection.
Okay. Then, clinical picture of aortic stenosis.
Clinical picture of in case of mild, it may be asymptomatic. In case of moderate, patient present with angina, syncopal attack, and dyspnea. In case of severe stage, patient will come with a complication like MI and pericarditis and sudden death.
Okay. So, next question. What are the surgical options to treat aortic stenosis?
Surgical option. Three options: mechanical valve, tissue valve, and Ross procedure.
Okay. Then, what are the difference between mechanical or pathophysiology of aortic stenosis? Okay, you can tell me how does aortic stenosis leads to death?
Okay. Due to fixed cardiac output, patient cannot respond to the decreased afterload.
Yes.
So which? Hmm.
Hello?
Yes, I'm
Huh.
done.
Oh, you're done. Okay. Next one.
Yes.
How does aortic stenosis lead to sudden death?
Lead to sudden death.
Yes.
Mm. In case of aortic stenosis, please
Yes.
shift to the another question.
Okay. Then difference
Hmm.
between mechanical and tissue valve.
Mechanical valve.
Yes.
Mechanical valve made of metal or ceramic uh, in- elements, and tissue valve made up of animal or human tissue. And it has highly mechanical. In case of mechanical valve, it has highly thromboembolic and bleeding manifestation tendency. In case of tissue valve, there is a low risk of thromboembolism and bleeding risk. In the durability, chance of reoperation in case of metal in mechanical valve is low. It persists almost a lifetime, but in case of tissue valve, it will wear out maybe after 10 to 20 years. So, and warfarin is prescribed lifelong for mechanical valve, but in case of a tissue valve, warfarin is not needed for lifetime, only after 3 months following surgery.
Okay. What is the non-surgical option for valve replacement?
Um, it's transcatheter aortic valve replacement. Another is aortic valve balloon valvoplasty.
Okay. Then next question is, if valve, uh, if there is a metallic replacement has been done in case of valve, okay, and the
Yes.
patient developed infective endocarditis after that, what will be your next step?
I should remove the valve as soon as possible because it's itself a septic foci, and the valve may cause dehiscence. And as there is no blood supply to the mechanical valve, it may cause biofilm, so which is may not respond. It's difficult to eradicate by antibiotic.
Okay, my next question was why. You have already answered that. Okay.
Yes.
Next one. If you find microscopic branching hyphae on the removal of valve, what is the
Hmm.
cause and the type?
The cause may be for fungal infection, and they are maybe it can be affected by Candida albicans and Aspergillus.
Okay, then your next question is, a patient comes to you with mechanical valve replacement. After a while, they started complaining of arm weakness. Why?
Due to a venous thromboembolism, which may causes cerebrovascular. incident.
Okay.
Blockage.
Do you prescribe anticoagulant post-valve replacement?
Yes.
Okay. And what is the duration?
It depends on the type of the valve. If it is mechanical valve, I will continue lifetime, and if it is tissue valve, I will continue 4 months, 3 months after the procedure.
Okay. What is the common anticoagulant used for outpatient?
Warfarin.
Okay. Then mode of action of warfarin.
It inhibits the vitamin K dependent coagulating factors 2, 7, 9, and 10.
Okay. Then next question, what is the pathway? Which pathway is not affected by warfarin?
Intrinsic pathway.
Okay. Sorry, can you please repeat again?
Intrinsic pathway.
Okay. Okay. Then warfarin works in 3 pathways. Okay. Which
Yes.
pathway is not affected?
Intrinsic pathway.
Okay. Describe the common pathway of clot formation.
Okay, both intrinsic and extrinsic pathway converges to activate factor 10, and then factor 10A and factor 5 together with calcium and phospholipid activates the prothrombin to thrombin. Then thrombin activates fibrinogen into fibrin, which causes a mesh-like structure that traps platelet and blood cells, forming blood clot.
Okay. Then your next question is define thrombus.
Yes, thrombus is a constituent of blood cells from produced inside the blood vessels.
Okay. What type of complication happens to a non-displaced thrombus?
First of all, occlusion, inflammation, and infection.
Okay. What test will you do if you suspect that the thrombus is infected?
I will see test for blood tests. I will go for some blood tests, complete blood count, infection, inflammation marker, CRP, ESR, and blood culture.
Okay. What is CRP?
It is an acute phase protein, which is produced and secreted by the hepatocyte in response to acute inflammation.
Okay. And next question is what is the type of endocarditis that occurs in adenocarcinoma?
Could you please move to the another question?
Okay. What are the antibiotics guideline in a patient with aortic stenosis?
No antibiotic is needed if there is no complication. Otherwise, in case of major surgery and in case of highly infective surgery, such as lower and upper GI tract surgery.
Okay. Name a single blood test to monitor antibiotic response to infective endocarditis.
Single blood test.
Yes.
Um, could you please shift to the another question?
Okay. So here the station ends on also your time. But if I do have time, I would ask you the previous 2 questions which you have skipped. Okay.
Yes, please.
So here you have actually, firstly, I would like to say you have done great. Okay. It was a really
Thank
big
you.
station. Here you have just answered really good, really flawlessly. Extra 1 and 2 mistakes which are not actually mistakes, or it is a mistake. That is when I'm asking you the specific question, just answer that one, yes or no, that specific, don't elaborate. Okay.
Okay.
Because the elaboration
Okay.
could be the next question.
Okay. Okay.
Okay. So here
Okay.
infective endocarditis So our first question was, why is bicuspid aortic valve susceptible to infective endocarditis? You have given the right answer, that as bicuspid has two flaps, that will and if there is infective endocarditis, there will be narrowing and obstruction of the open, which will make it difficult for the blood to pass through it. That will cause the stasis. And if there is stasis, there is more chance of bacterial growth, and that will increase the risk of infective endocarditis. Then pathogenesis. So, and in bicuspid valve, when you're getting in the station, you should read it, whether it is bicuspid stain or tricuspid stain. Always answer according to the stain. Okay, so here bicuspid they were saying. So in bicuspid, same thing. There will be narrowing, so there will be stasis, there will be bacterial colonization, there will be damaging of the tissues, and there will be, for this recurrent attacks, there will be inflammation that will cause progressive fibrosis, and this fibrosis will later on will cause narrowing and stiffening of the valve, that will cause the stenosis. Okay, when you're going to say those words, they will just tick it in their checklist. Next one, investigation of choice, you said the right thing, 2D echo. Then next one, what are you looking for 2D echo? There are 7 points. So there will be regurgitation, the leaflets will be prolapsed and thickened, there will be annular dilatation, caudal elongation or rupture, increased echogenicity, there will be pericardial effusion and ventricular dilatation. You have said only 5. Other 2 you have said etc. Okay, this one. Next one, what is the cause of sudden death in aortic stenosis? There are 2 causes. One is MI and another one is aortic dissection. You have answered correctly. Then next one is clinical picture. So in aortic stenosis, it has like 2 stages, like mild, moderate and severe. In mild, there is asymptomatic. In moderate, he will have this angina, syncopal attack and dyspnea because of less blood supply to the brain, and also because the heart cannot pump more blood, so he's having this angina. And in severe cases, the patient will have pericarditis, then MI, and suddenly he could die due to this MI or pericarditis. Now, here I have just written some, like, what are the signs. Sometimes in the station they could, like, there were pulses alterance, there is narrow pulse pressure. In the echo, there he is finding ejection systolic murmur, splitting S2, all these things. Then, what is the surgical options? You have said the right one, the valve replacement, then Ross procedure, TAVI, TAVR, all those things. And okay, next one is pathophysiology. Okay, here in the exam, some questions there are only 1 marks, and some there are like 2 or 3 marks or 4 marks. So this one is a bigger one which has more marks, like 3 to 4 marks. Okay, so and you have just said in 1 sentence, don't. Okay, here you have to explain this one. So here what is happening in aortic valve, aortic stenosis, what is happening? From sclerosis there is stenosis. Okay, so stenosis means more afterload is there is more afterload because of systolic ejection is more, because the heart is trying to pump out more blood, and this is later as the heart is working more and more, so there is left ventricular hypertrophy, and this as there is like more left ventricular hypertrophy, there will be some changes in the ventricles. That is what the elasticity is decreasing, and also the blood flow. And what is happening as the blood is staying there more time, so the myocardial workload is getting increased. And what is happening as there is more work is going inside the left ventricle, so more need for oxygen consumption and more chance of mortality. And there is another thing, as the left ventricular hypertrophy is happening, what is happening in the outside, the musculature thickness is getting increased more and more, so that inside the left ventricular, the chamber wall is getting smaller. Okay, which is also decreasing the preload and also decreasing the systolic function. Ultimately, this is causing that thing we have read, just MI and aortic dissection, or also the patient come to us with its angina, syncopal attack, dyspnea, all these things. This happening due to the pathophysiology. Okay, and then how does aortic stenosis lead to sudden death? Same. MI, because of this increased workload. Then the difference between mechanical and tissue valve, you have answered perfectly. And what was that? So at first you have to say one is metallic, one is like from a tissue valve from another either from a different species. And then what is the difference? There is in mechanical the durability is more, and in the tissue it is noiseless. And in mechanical, lifelong warfarin is needed. In tissue valve, there is no need for warfarin. And then the operation. In case of mechanical, it is hard to insert. That one is for tissue. It is easy. No, sorry. In mechanical, it is easy to insert, but in tissue, it is hard to insert. And in case of mechanical, the chance of thromboembolism is more. That's why we are giving lifelong warfarin. And in tissue, there is less chance of thromboembolism. And also in mechanical, as we are giving the warfarin and everything, so bleeding risk is a bit more. And in case of tissue, there is low chance of bleeding. Then the next question is, what is the non-surgical option for valve replacement? That is three things: balloon valvoplasty, TAVI, and TAVR. Okay, next one. Okay, if valve is metallic and the metallic replacement has been done, but the patient developed infective endocarditis, what is your next step? So this answer will be, we will plan to remove the valve. Then when he will ask why, then you will answer because it is a septic foci. Why? Because in fact mostly there are some bacteria, like Hassett bacteria, then Streptococcus epidermidis, which will cause a biofilm. And also this is, as it is a metallic thing, antibiotic would not work properly because it has no blood supply. Okay. Then if you find microscopic branching hyphae on the removal of valve, what is the cause? So that will be fungal infection. Then when he will ask you what are the types, then you will say the types like Candida, Aspergillosis, Trichophyton, Mycosporum, Epidermophyton. Next, a patient comes to you with mechanical valve replacement. After a while, they started complaining of arm weakness. So that is why, that is thromboembolism. Somehow the clot dislodged and went to our cerebrovascular system, and it causes the stroke, and that's why the patient is having arm weakness. Then, do you prescribe anticoagulant post valve replacement? You said yes, we do. Then I ask the next question: what is the time and duration? For mechanical, it will be lifelong, and for tissue, it will be 3 months. Then what is the common anticoagulant used for outpatient? Warfarin, as we can give the patient orally. And mode of action, so warfarin works on the vitamin K dependent clotting factors. It prevents those. What are the vitamin K dependent clotting factors? Those are 2, 7, 9, 10. Then I have make this mistake here, a small mistake. Which pathway is not affected by warfarin? That is intrinsic. And warfarin works in 3 pathway, which is not affected. That is the extrinsic one. And now the next one, which you answered.
I didn't get you. Hello.
Here I have made a mistake. Okay, so which pathway is not affected? It will be intrinsic. Okay.
Yes.
And warfarin works in 3 pathways. Which is not affected? That will be extrinsic.
Okay.
Okay.
So could you please explain it, because I don't have any idea about this.
Here, this is something you have to memorize. Okay, when we had this problem a lot. Okay, we have debated each and every time. Later on, we all came to a decision. Okay, this is said somehow it was on the checklist. We found this out, and then we are just memorizing that one. Okay, this warfarin and which extrinsic or intrinsic, what not. Actually, warfarin is working on the both pathways actually. Okay, here once my colleague she has said that it works on both extrinsic, intrinsic, then ultimately going to the common pathway. But when it is said what warfarin, which pathway is not affected, that will be extrinsic, and which part that's it, not extrinsic, that's it. Enough. Sorry. And then describe the common pathway. So common here, the intrinsic and extrinsic. Okay. So extrinsic mean outside our body or somehow when there is tissue involvement of tissue, extrinsic. Okay. So tissue factor is 3, and then next factor is extrinsic. There are like only two clotting factors are there. One is 3, another is 7. Okay. And in case of intrinsic, I have remembered all the more of the clotting factors are working here. So that is
8, 9,
uh
11, 12.
yes, 12, 11, then 9, and then 8. Okay.
Hmm.
Here the common pathway, they have asked only about the common pathway. I have remembered 5 times 2 is equal to 10. Okay, so by the help of 5 and 2 means to prothom bit, it is activate the 10 is working, converting into thrombin. Okay, then from thrombin, fibrinogen, by the effect of fibrinogen, it is converting into fibrin clot. Then by 13 and calcium, it is converting into the fibrin mesh, that thing. Okay, so here the thing, prothrombin is converting to thrombin by phospholipid 5A and 10A. Okay, prothrombin to thrombin by 5 and 10. Then by the act of fibrinogen, which is 1, it is converted into fibrin clot. Fibrin clot. Okay, then from the fibrin clot, by the help of factor 13, it is causing cross-linking, and then the clot is formed. That is
Okay.
okay. So next one, define thrombus. So there are two things. Okay, one is thrombus and another one is emboli. Okay, so when it is at the same position, it is thrombus. But when it dislodged from the space, it is called emboli. But normally, if there we say that okay, we are a patient. So what is at first I would say what is thrombus? So it is the product of clotting pathway and remains in the same position, forms from the constitution of blood and remains in the same position. Okay.
Okay.
So here one thing, and when they will ask define emboli, same it will be the answer, except remain it is a movable constitution of blood. Okay, it will move, it will not stay at the same position. Then next question, what are the complications which happens to a non-displaced thrombus? Okay, so if it is non-displaced, that what will happen at the base, the thrombus will stay. So it will at first there will be infection, from infection there will be inflammation. Okay, and then from the inflammation there will be sloughing and necrosis, and there will be dislodgement. Then what test will you do if you suspect that the thrombus is infected? At first we will do blood culture. Okay, because by which infection it is infected, we have to get it out. So blood culture, then ESR, then CRP. Okay, what is CRP? So it is acute phase protein which is secreted from the liver or hepatocyte in response to inflammation, and these are like which we have read, cytokine or interleukins. Okay, and it is a good prognostic factor which is used to follow up of the patient. Okay, but it is we have to do blood culture to get the origin of the infection. So CRP is just prognostic factor for a follow-up. That's it. Next, what is the type of endocarditis that occurs with adenocarcinoma? That is Liebman-Sack endocarditis. Can you please tell me what there is another okay, can you please tell me what are the types of types of endocarditis?
Yes. Liebman-Sachs endocarditis.
And another?
I have no idea.
Okay, and one is infective endocarditis, another one is non-bacterial thrombotic endocarditis, and another one is Liebman-Sack. Okay, Liebman-Sack is linked with adenocarcinoma, and non-bacterial thrombo, that one is related with SLE, all those autoimmune disease, non-bacterial one. Okay, So next one, what are the antibiotic guidelines? Which you have answered correctly. That is like normally there is no prophylactic antibiotic given for a patient of aortic stenosis undergoing procedure. But if that is highly infected case, we would give antibiotic prophylaxis. You have said other thing like if the patient is going for dental procedure or upper and lower GI tract operation or surgery, then we will give antibiotic prophylaxis. And what is the guideline? It is a nice guideline. Okay, here this one I have just added because somewhere maybe in some station they have asked what are the anaerobic culture medias. Can you just tell me after that? After this question, name a single blood test to monitor antibiotic response to infective endocarditis. That is blood culture. After that, any kind of anaerobic culture media do you know about? That was the soy agar media or Scadler media or LKB or BBE media. Okay, so next one. Okay, here. Do you have any questions or anything you have any concern? Hello.
No, thanks. I have cleared all of the confusions.
Okay. So, is there anyone else who would like to have would like to participate with me on the second mock?
Yes, yes.
Okay. Okay.
I'm
So,
Dr. Nimra.
okay. Hello, Dr. Nimra. So, Dr. Nimra, here I have a station. There, I have said in my flyer that I would ask questions from temporal arteritis and osteoporosis, but there are some questions from BCC. Okay, one or two questions. Don't worry. Okay. So,
Okay.
at first, before going to the station, you would have a scenario. And here is a scenario which will you get 1 minute to go through it. Read it really carefully, okay? Because you have to answer according to your state. Okay, what you have read in your book, you cannot stammer that in the mock. You have to answer according to your scenario. So the scenario is a 78-year-old diabetic comatose patient is referred for temporal artery biopsy, having described shoulder pain and tender scalp for 1 week. When performing a temporal artery biopsy, you noticed a nodular lesion with some ulceration over chin of the patient, suggestive of primary skin cancer, most commonly basal cell carcinoma. Okay.
Okay.
So, should we go to the stations?
Yeah, sure.
Okay. So, your first question is, why is the temporal artery being biopsized in this case?
To identify giant cell arteritis.
Okay. What is the usual medical management for this condition, which may have been started before the biopsy?
At first, start with prednisolone, 60 milligram per oral, immediately.
Okay. Next one. Why is steroid therapy often taken before the biopsy is taken?
To reduce maybe due to involvement of the ophthalmic artery,
Okay.
to prevent this. Yeah.
Okay. What 4 items of data you want to see in a pathology report regarding skin cancer?
Can you please say it again?
Sure. What 4 items of data you want to see in a pathology report regarding skin cancer?
I have no idea. Can you move to the next question, please?
Okay. What features of tumor may get inside of the risk of metastatic disease?
Uh, uh,
What
yeah.
feature of the tumor may get inside of the risk of metastatic disease? How will you know the tumor is metastatic?
Okay, lymph node involvement
Okay. Next question. Why blindness?
due to ophthalmic artery involvement. which supply the retinal artery.
Okay. Which commonly performed single lab test is done?
Yes, sir.
Okay. What is the mainstay of management of temporal arteritis?
Temporal arteritis management.
Yes.
Management you are talking about?
Yes.
Yeah. At first, start with prednisolone, 60 milligram per oral immediately, then or IV methylprednisolone 80 milligram if there is a any chance of visual loss.
Okay. Then a patient came back after a year with neck of femur fracture. What are the possible risk factors for the pathology of fracture in this patient?
Okay. In this patient,
Yes.
okay, because the patient is female, postmenopausal woman, elderly, and due to long term steroid therapy.
Okay. What? Okay. Other local pathology that could cause this fracture in this elderly lady. Mention 4.
Pathological fracture.
Okay. Yes.
Okay. Due to osteomalacia, Paget's disease, hyperparathyroidism, and maybe like metastasis.
Okay. What is the pathology of osteoporosis?
Osteoporosis pathology. Maybe decrease. I'm sorry. Next question, please.
Okay. What are the perioperative concerns and how to address them?
Perioperative concern.
Yeah.
Or steroid coverage to prevent the Addisonian crisis and electrolyte imbalance.
Okay. Then, 6 months later, this patient is admitted for a mechanical fall in the community. Radiology shows she had a fracture of the neck of femur and needed surgical intervention. Which of these factors in this case will predispose to her to an osteoporotic fracture?
Uh, uh, Sorry, I don't get it.
Okay, again I will say 6 months later, this patient is admitted for a mechanical fall. Radiology shows she had a fracture of neck of femur and
Okay.
needed surgical intervention. Which of these factors, the above factors you have mentioned, in this case will predispose her to an osteoporotic fracture?
Maybe due to steroid therapy.
Okay. From the biochemical report in acute osteoporotic fracture, what will you suspect the serum calcium and phosphate level to be?
In osteoporosis, both are normal.
Okay. Then the next question is, on operation, the bone material was found to be soft and fragile. A sample was sent for histopathology. The pathology report is then showed to you, and you have found a plasmacytoma or myeloma. What is myeloma?
Myeloma. It is a carcinoma from epithelial origin.
Okay. Okay. What makes such a tumor commonly secrete in the serum?
Commonly secreted in the serum.
Yes.
Uh, Next question, please.
Okay. What is Benz-Jones protein?
Baines-Jones protein. It is a protein. Uh, Baines-Jones protein. It is a protein found in multiple myeloma.
Yes. Okay. Apart from osteoporosis, what might be the risk of fracture?
Um, due to osteomyelitis,
Okay,
osteogenesis imperfecta.
okay. Then, after fracture repair, some radiotherapy is planned. The wound site has poorly and aseptically broken down after 5 days. What 4 factors are likely to predispose to sepsis here?
Uh, 4 factors.
Yes.
I'm sorry.
Okay.
Next question, please.
Despite antibiotics, the hip infection persists. After several weeks of therapy, excision of the hip and rib, followed by total hip replacement, was undertaken. However, she died after cardiorespiratory failure after the 24-hour of surgery. What are the 2 most likely cause of her sudden death based on the data provided from the case?
Actually, the question is too long. I couldn't recognize actually.
Okay, so despite antibiotics, there has been a hip infection. So after several weeks, there has been total hip replacement surgery. However, she died after 24 hours due to cardiorespiratory failure. What are the 2 most likely cause of her sudden death based on data provided from the case?
Pulmonary embolism or fat embolism.
Okay. What is the pathology of giant cell arteritis?
Giant cell arteritis. Granulomatous inflammatory disease. Maybe like intimal thickening.
Okay. Okay. So, would you like to go back to the questions which you have skipped?
Yeah, please.
Okay. What 4 items of data you want to see in a pathology report regarding skin carcinoma?
Okay.
Would you like to answer this or not?
No, please. Please, you tell
Okay.
me.
So your time is up. Actually, it has been a 10-minute station. Your time has been up. So one thing is when you're not sure about the question, you would just tell the examiner just that I would like to come back to this question later on. Okay. Sometimes if you say I don't want to answer, they would not ask you. If you say that I would come back to this station later on, this question later on, they will ask you again after you have gone through all the questions. Okay. One thing.
Okay.
So here, now we would discuss this station. So at first, elderly lady who has diabetes, and she has been referred for a temporal artery biopsy. Okay, and also she has some ulceration over the chin, and most likely it is basal cell carcinoma. So why the temporal artery being biopsized? You have given the right answer. It is because it is a because to identify whether it is giant cell arteritis or not. Because temporal artery, it is a big vessel. Not normally when it is infected, it is said called to be giant cell arteritis. Next, how to prevent this? We would give high dose corticosteroid because it will cause less chance of edema, and also there will be less chance of visual impairment. Normally after we do any kind of end artery biopsy, like here in this case temporal artery biopsy, there would be loss of vision. To prevent loss of vision and also to prevent the edema, we would give high dose corticosteroid. Next was, why steroid therapy often taken before the biopsy is given? The biopsy is done, same answer, to protect the vision, as the artery may involve the ophthalmic artery, which is an end artery. That's it. And then this question, which you have you were not able to answer, that is, what 4 items of data you want to see in a pathology report regarding skin cancer? So it will be the type of tumor, the diameter of tumor, the thickness, the margin clearance, and if there is any lymphovascular invasion. And it is a really important question.
Okay.
When we will maybe discuss about the basal cells, squamous cell, that those stations, you will get this question invariably. Next question, you have answered this one. What features of the tumor may get inside of the risk of metastatic disease? That is the presence of absence of, you have only said lymphatic invasion. That will be both lymphatic and blood vessel involvement. Oh, here sometimes the questions are a bit hard to understand. Sometimes you would have some problems to understand your examiner's accent, but that time ask the examiner repeated times. So, sir, can you please again simplify this? Can you please tell me again the question? How many times you would ask, they would answer. But always keep in mind that you should go through the whole station. Okay, if you're thinking it is taking more of my time, then just tell the examiner, sir, I would like to come here back later on after the whole station ends. Okay, they would come to you. Okay, next, why blindness? I had answered this one because involvement of ophthalmic artery, which is an end artery. And here, this one you have answered wrong, which commonly perform single lab test, that is CRP. Okay, to get the prognosis, whether the patient is getting well or not, we do check the CRP. Then,
Okay.
what is the mainstay management of temporal arteritis? You have answered this correctly, that is steroid. Then, the patient came back to you with neck of femur fracture. What is the possible risk factor? Okay, so she's an elderly lady, menopausal lady. Most common factor is osteoporosis. One answer only. Then, what are the other four pathological causes which could happen? Then you would say there could be osteomalacia, there could be Paget, there could be hyperparathyroidism, there could be metastasis. Okay. Then what is the pathology of osteoporosis? In osteoporosis, normally the bone is normal in everything, like mineralization in type, but there is less volume. Okay, the bones become vacuolated. There is emptiness between the bone. Okay, there are like air space or bubble space like that. Then what are the perioperative concern and how to address them? So the patient is having a steroid coverage. Okay, so anytime if you stop the steroid, the patient will have this Addisonian crisis. All of a sudden, the patient could have this shock, or like she will get unconsciousness. All this is due to this steroid. Okay, because when you're on steroid, our body cannot produce the steroid by our body does not produce the steroid by itself. Okay, that's why we always have to taper the dose of steroid, because at that time our body starts to adjust the secretion of steroid accordingly. Okay, from the adrenal gland we have from the fasciculata, from where the steroids are getting secreted. Okay, we have read that thing. So to adjust that and to prevent the Addisonian crisis, we have to keep that in mind. Next one is this one. Oh, sometimes they will. I have told earlier in our session that sometimes the station could be really long, and there could be big stain. So it is really hard for the participant, for the candidate, to get what the examiner is asking. So here, try to put your concentration in the exam, one thing, and secondly, if you're not able to get what the examiner is saying, ask him. Okay, they are there to help you. They would how many times you will ask, they will answer you. Okay, so just ask him, sir, I'm not able to understand, can you please repeat, which you have done, which is really praiseworthy. Okay, so here 6 months later, the patient admitted for mechanical fall. Then there is a radiology done which showed a fracture of the neck of femur, and this needed surgical intervention. So what was the cause, okay, for this fracture? So this is still the continuation. So the elderly lady still on steroid therapy, and after 6 months she is having this fracture. Okay, so the answer will be steroid. And here the patient is having fracture due to steroid. Okay, this osteoporosis happening due to steroid, not due to parathyroid. Okay, our body's parathyroid normally maintains this calcium or phosphate level, but as it is not due to parathyroid, so as this is only due to steroid, it is an cause outside the factor of parathyroid, so the serum calcium and phosphate level will be normal. Then next one is on operation. The bone material was found to be soft and fragile. It was sent for histopathology, and this pathology report showed a plasmacytoma or myeloma. Here you have answered another thing. I know that epithelial one, that one is also correct, and this one is also correct. That neoplastic monoclonal proliferation of plasma cell. When there is plasma cell proliferation, it is called myeloma. Okay, this next question which you were not able to answer: what may such a tumor commonly secrete in the serum? Okay, so it is a what is myeloma. Okay, for that the tumor is happening, and in case of myeloma there is fragmentation of immunoglobulin. Okay, the immunoglobulins are getting fragmented, so we will find the fragmentation of immunoglobulin in serum. Next question is, what is Bence-Jones protein? That is immunoglobulin light chain. There is like in case of any kind of immunoglobulins, there are like two chain. One is light chain and another one is heavy chain. Okay, so Bence-Jones protein is the light chain. Okay, that is found in urine after the breakage of immunoglobulins. In a urine sample, when you will find the light chain, okay, only the half of the immunoglobulin, that is called Bence-Jones protein. Next question. Apart from osteoporosis, what might be the risk of fracture? She is an elderly lady, she is emaciated, she is having this pathological fracture. So we will think of metastasis or any kind of carcinoma. So here the answer is bone lysis by tumor. Then after the fracture is repaired, some radiotherapy is planned. But the wound is poor and aseptically broken just after 5 days. Okay, mainly the thing is why the patient is having this infected wound. So the four things you have to answer this according to the state. At the beginning, it has been mentioned that she's diabetic, she's elderly. Then on by the going through this of this station, we have read that she's having steroid therapy, and also as she's elderly, and also just the previous time there has been myeloma or plasmacytoma. So due to this plasmacytoma, there is decreased immunity. And another thing, she has been she's having a fracture. For that she's having another operation. Okay, so there is a presence of foreign body. So these are the four stations, four factors. Okay, there I have read maybe in some other stations which has been the stem has been changed. Okay, so people have read according to their book, but in the exam the stem has been changed slightly. Okay, there has not been mention of diabetics. Okay, but people are saying diabetic, so that is not in the chart. Okay, checklist, so you will not have the mark, they will cross it down. So this is the question. Next one. This one you were saying sometimes the stem could be long, like our MRCS part A. So despite of antibiotics, the hip has been infected. So the patient has gone through hip replacement and she died 24 hours after the surgery. Then they have asked what are the most common cause. So if there has been any kind of hip replacement, if there has been any work with the bone, so most normally within 24 hours, the patient if the patient dies, it is due to fat embolism. Yeah, there is like bone marrows and everything inside the bones. Okay, there is like somehow the bone marrow or there are like a lot of fat. If the fat dislodged from there and gets into our blood vessel, it could cause fat embolism. Okay, the patient became really septic, she becomes toxic, and then she dies due to cardiovascular. So your first point would be fat embolism. Okay, so here you will have a negative mark, they will cut your mark because you didn't see that fat embolism. Then it is due to clot dislodgement, that is venous thromboembolism. Okay, and also if there you want to say another one, Here they have said only two. You just answer two. And any other thing is renal vein thrombosis. Okay. Then next one is, what is the pathology of giant cell arteritis? So we have had a class previously where we have read about this arthritis thing. So mainly the pathology is there is fibrinoid necrosis, and when we have the histopathology, it will show lymphocytes, there will be plasma cell, and there would be polynuclear histiocyte cells. Okay, three cells: lymphocyte, plasma cell, polynucleated histiocyte cells. Okay.
Okay.
So here my session is ending. Thank you. Do you have any other questions? Hello.
Thank you, Dr. Nafidu.
No, thank you.
Sorry.
Hello.
Hello, Doctor.
Yes.
Thank
Do you
you.
have any
I
other
have no
questions?
no question. Thank you.
Okay, thank you. Okay, Dr. Piali and Dr. Nimra, you both did really great. Actually, you have passed the station with flying colors. Don't worry. Whenever you will sit for the exam, just practice more and more. Okay, because this exam is actually according to how well you are saying. Okay. That would I would like to say, and I would like to thank you all. Thank you so much for being there. Next time I would again come with some another class and mock stations. I hope you would all be there. Okay, so thank you so much, and assalamu alaikum.
Walaikum
Thank
assalam.
you.
Okay.
Thank you.